Circulatory failure. It is a silent, rapid, and just absolutely ruthless process. It can devastate the human body in literally a matter of hours. When a patient enters a state of shock, the clock isn't just ticking. It's practically sprinting toward irreversible organ failure. Welcome to this explainer. Today we're taking a highly methodical, incredibly urgent clinical journey to really understand this life-threatening condition, figure out how to spot it before it's too late, and look at the cutting-edge tools clinicians are using right now to fight back.
Okay, let's dive into this. We've got a tight roadmap for our journey today. First up, defining the silent killer. Then, we'll look at the 4 phases of shock, followed by the pediatric reality. After that, we're getting into the technological heroes of our story, diagnostics using POCUS and AI. And finally, we'll wrap up with the critical timeline known as the golden 15 minutes.
Section 1. Defining the silent killer. Now, when a lot of folks hear the word shock, they immediately think, oh, it's just a simple drop in blood pressure, right? But as we're about to see, a drop in blood pressure is just one tiny piece of a massive systemic crisis.
The absolute core of it all is this. Shock is fundamentally a state of global tissue hypoperfusion. What does that actually mean for the patient? It means the real enemy here is cellular energy failure. The cardiovascular system is completely failing to deliver enough oxygen and glucose to the tissues that desperately need them. This hypoxia completely disrupts basic cellular function and forces the body to shift over to anaerobic metabolism. And that shift? It produces lactic acid, which leads to systemic acidosis, endothelial dysfunction, and eventually cellular death. It is literally a molecular catastrophe happening all over the body, all at the exact same time. Now, because of this massive crisis, the body obviously tries to fight back, which kicks off what we call compensated shock. At this point, the body senses the drop in volume or cardiac output and just goes into complete overdrive. It clamps down on peripheral blood vessels and ramps up the heart rate, all to keep those vital organs perfused. Believe it or not, the blood pressure actually stays normal here. But eventually, those compensatory mechanisms just run out of steam, leading to decompensated shock. The body's defenses are totally overwhelmed. This is where blood pressure completely plummets, and we start seeing signs of severe end organ dysfunction, like confusion or altered mentation. Section 2. The 4 phases of shock. Now, to effectively treat shock, we have to figure out exactly what's causing the system to crash in the first place. Basically, there are 4 primary categories of shock. First up, distributive shock. This is essentially severe peripheral vasodilation. Think of it like the pipes just getting way too wide. Sepsis is your classic example here. Second, hypovolemic shock. This is a critical loss of actual fluid volume, maybe from massive bleeding or just really severe dehydration. Third is cardiogenic shock, where the heart muscle itself is failing as a pump, which you often see after a massive heart attack. And finally, obstructive shock. This is where a physical blockage outside the heart, like a massive blood clot in the lungs or fluid squeezing the heart sac, stops the blood from circulating. So, how do clinicians tell these apart in a fast-paced critical care setting? Well, they look at classic hemodynamic profiles. A really key differentiator here is systemic vascular resistance, or SVR. Basically, how tightly clamped down are those blood vessels. In hypovolemic shock and cardiogenic shock, SVR is super high because the body is desperately trying to squeeze whatever blood is left up to the brain and the heart. But contrast that with distributive shock. There, the SVR is severely decreased. The vessels are completely relaxed and leaky. Understanding these exact physiological parameters is exactly how medical teams pinpoint which of the 4 phases they're actually dealing with.
Section 3. The pediatric reality. While shock is incredibly dangerous for anyone, how it presents in children is uniquely terrifying. This number is honestly just stark, 45.5%. A prospective study highlighted by Dove Medical Press found this to be the overall mortality rate for children presenting with shock at their studied facility. Almost half of these pediatric patients didn't survive. To put that into perspective, it just completely drives home the absolute urgency and the insanely high stakes involved when a kid's circulatory system starts to fail.
Now, what's really interesting about this data is the breakdown of when these children are actually arriving at the hospital. If we analyze the compensated cases versus the decompensated cases, a pretty grim pattern emerges. Notice how for both hypovolemic and septic shock, the decompensated cases just heavily dwarf the compensated ones. What does that mean? It means the vast majority of these kids aren't arriving in that early, manageable stage. They're showing up late, at a point where their bodily defenses have already completely collapsed.
And if we zoom in on the leading causes of pediatric shock specifically, hypovolemic shock makes up the vast majority at 53%. This is often from severe fluid loss, things like severe diarrhea or vomiting. And that's followed closely by septic shock at 34.4%. You put those together, and those two alone account for nearly 90% of all pediatric shock cases.
Section 4. Diagnostics using POCUS and AI. So, if late presentation is our main enemy, how do we fight back? Well, we have to diagnose the exact cause of the shock immediately.
How do we identify shock faster? Because let's be real, in the emergency department, time to diagnosis literally dictates survival. You simply cannot wait around for standard lab results to come back when a patient's organs are actively shutting down.
The game changer here is point-of-care ultrasound, or POCUS. When an emergency room doctor uses POCUS, the diagnostic accuracy of undifferentiated shock leaps from roughly 60.6% all the way up to an incredible 85%. That is a massive jump in diagnostic certainty. And it allows doctors to give the right life-saving treatment minutes, if not hours earlier.
Let's look at how this actually plays out in clinical practice. Doctors use these standardized ultrasound assessments, and the most notable one is the RUSH protocol. It's elegantly simple, and the whole thing takes less than 2 minutes. Step 1. They check the pump. So they look at the heart to see if the ventricles are failing or dilated. Step 2. They check the tank. They're looking at the inferior vena cava and the abdomen to see if the body is just completely out of fluid volume. And step 3, they check the pipes. They scan the major vessels, like the aorta, looking for ruptures or deep vein clots. Pump, tank, pipes. It's just a brilliantly effective way to visually map out a failing system.
But wait, we're pushing the boundaries even further now with artificial intelligence. Modern ultrasound machines are packed with AI tools. Take real-time ejection fraction, for example. It continuously calculates exactly how well the heart is pumping the literal second the probe touches the chest. Or the Auto IVC Collapsibility Index. It automatically measures the minimum and maximum diameters of the patient's veins to instantly tell the doctor, hey, this patient needs more IV fluids. AI is quite literally saving crucial seconds by doing all the complex math automatically in the background.
Section 5. The golden 15 minutes. We've defined the problem, categorized it, and diagnosed it. Now, we have to act. Managing shock is an absolute race against the clock to reverse that totally destructive biochemical cascade we talked about earlier. At 0 minutes, the literal moment shock is suspected, you call for help and secure the resuscitation room. By the 5-minute mark, the airway has to be secured, and that initial isotonic crystalloid fluid bolus, which is usually 20 milliliters per kilogram for kids, is already pushing into their veins. By 15 minutes, the patient is reassessed. At that point, up to 60 milliliters per kilogram of total fluids should be administered if they're in severe shock. It's a rapid-fire, highly protocolized rescue mission. Every minute counts. But I want you to remember this absolutely crucial clinical pearl, especially for the pediatric cases. Hypotension is a late finding in pediatric patients. Kids have amazingly resilient cardiovascular systems. They can clamp down their blood vessels and maintain a completely normal blood pressure even after losing up to 45% of their total blood volume. That is wild. By the time their blood pressure actually drops on the monitor, they're already on the very edge of complete cardiovascular collapse. You absolutely cannot wait for the blood pressure to fall to start treating them.
Which leaves us with this final vital thought. Shock is stealthy, it's rapid, and it's highly lethal. In a condition where every single second counts, is your clinical intuition faster than the biochemical cascade happening right there at the cellular level? And that right there is exactly why rapid, systematic protocols and immediate visual tools like POCUS and AI aren't just cool optional gadgets anymore. They are absolute necessities in modern medicine. They give us the speed we desperately need to outrun the silent killer. Thanks so much for joining me on this explainer. Keep learning and stay curious.